Hi, I'm Dr. James Abbott, and I'm a part of the Tri-Service Workflow team. I want to talk to you today about the updated hypertension clinical practice guideline that was published at the end of 2014 by the Department of Defense and the Department of Veterans Affairs. I'll be discussing the major aspects of the DoD VA guideline, and I'll be comparing it to some of the other common guidelines that are out there for hypertension, like the one from JNC8. I'll be using the TSWF metabolic aim form as a way to bring you these details, and I'll finish up by showing you how you can utilize this aim form to help you care for and document on these patients. First off, let me tell you a little bit about this particular guideline. It was published at the end of 2014 after an extensive review of the literature as well as a review of the other guidelines for hypertension like JNC8. In fact, one of the committee members from JNC8 was also on the DoD VA working group, so they were well aware of the other existing guidelines out there. They ended up with 49 individual recommendations in the CPG. I won't cover all of them in this training, but you should take the time to review them all. If you click on the resources link at the top left corner, there's a link to the full guidelines. As opposed to JNC8, which only looked at blood pressure goals and medication choices, these recommendations cover a wide range of topics, including screening, diagnosis, and measurement of hypertension, adherence to therapy, lifestyle modification therapies, and pharmacological therapy. In addition to the individual recommendations, there are also two algorithms, one that covers screening and diagnosis, and one for treatment. We've dedicated an entire tab on the metabolic aim form to the DoD VA guideline for hypertension, and you can view both algorithms on that tab. The first algorithm deals with the initial diagnosis of hypertension. We don't want to rely on readings taken when the patient has an acute injury or illness, but provided that we have two readings on 2 different days, our patients can be split into one of 3 different categories. The first are those with a blood pressure under 120/80. This group has a normal blood pressure and should be screened annually. If, however, either of the readings are higher than that, but it's still less than 140/90, then they fall into the pre-hypertension group. These individuals should start lifestyle modifications such as diet, exercise, and weight loss. I'll talk a little more about some of the specifics of these recommendations a little later on. Finally, if either the systolic is over 140 or the diastolic is over 90 on 2 separate occasions in the office, then the diagnosis of hypertension is appropriate. The guidelines recommend some basic labs, primarily looking for target organ damage and some potential causes of secondary hypertension. One point I want to highlight before we move on to treatment. The 140/90 values are for office-based blood pressure readings. As we can see in sidebar B, sometimes it's appropriate to confirm the diagnosis of hypertension using either home blood pressure monitoring or 24-hour ambulatory blood pressure monitoring. There are lower thresholds for the diagnosis of hypertension when using these particular methods. Now that our patient has a diagnosis of hypertension, let's move on to the management algorithm, which is under the management ribbon of the hypertension tab. The first step here is to determine the patient's blood pressure goal. This is one area where our guidelines vary from the JNC8. For patients without diabetes, the DoD VA guideline gives a blood pressure goal of less than 150/90, regardless of the patient's age. JNC8 has a systolic goal of 140 instead of 150 for patients under age 60. Looking at that recommendation in the JNC8 guidelines, it's expert opinion. And to be honest, the literature shows that the diastolic goal of under 90 is probably more important for this age group, and that's an A-level recommendation for ages 30 to 60 in JNC8. Now, this isn't the only difference in treatment goals. JNC also recommended a lower systolic goal for patients with chronic kidney disease, but once again, that's based on expert opinion. Chronic kidney disease patients in the DoD VA guidelines have the same treatment goal as in non-diabetics, which is 150/90. Finally, we see a difference in goals for diabetics between the two guidelines. As we can see on the chart, for the DoD VA, we recommend a blood pressure of 150/85 with a lower systolic goal for patients that tolerate it. This varies from the JNC8 recommendation, which once again is expert opinion. Once we have a blood pressure goal and a patient willing to engage in treatment, it's time to pick a medication, right? Well, according to the algorithm, only 3 types of patients need to go directly to medication management. If the patient has a history of cerebrovascular disease, or if either the systolic blood pressure is 160 or higher, or the diastolic is 90 or higher, should you go straight to medications. If they are hypertensive, but with a systolic blood pressure of less than 160, you can start with lifestyle modifications and give it some time before starting medications. Following down the guideline, if their blood pressure is far enough above goal, the recommendation is to start out with combination therapy. Otherwise, we start out with monotherapy. In both cases, we recommend offering lifestyle modification interventions along with the medications. We'll get to those a little later on in the training. Now, in starting a medication, the guidelines give us a couple of evidence-based recommendations. For most patients, the preferred first-line drug is a thiazide-type diuretic, and the preference, if you read the full guidelines, is either chlorthalidone or indapamide instead of hydrochlorothiazide. The recommended doses for these medications are a little further down on the tab in the recommended dosage for selected hypertension drug therapy tab. For those that are used to the JNC guidelines, this is similar to what was JNC 7, but JNC 8 had several different classes of medications in their first-line category. The Working Committee for the DoD-VA guidelines felt that the literature still supports using the thiazides as first-line therapy in most individuals, including diabetics and in patients with a history of coronary artery disease. But there are a few special populations to talk about. For patients with chronic kidney disease, the recommendation is that they should use either an ACE or an ARB as first-line therapy instead of a thiazide. And in African American patients with kidney disease, they recommend combining this ACE or ARB with a thiazide due to the increased risk of stroke in these patients who are on an ACE inhibitor or an ARB by themselves. Well, that pretty well covers the basics of diagnosis and pharmacologic treatment, but our guidelines also focus on lifestyle modifications, so let's look at those. The recommendations fall into the following areas. We've placed details about all these items on the DoD-VA Hypertension tab to give you an idea of the various recommendations and what kind of systolic blood pressure reduction you can expect. I want to just quickly highlight a couple of these. First, when it comes to exercise, the recommendation is for patients to engage in 30 to 45 minutes of aerobic activity 4 times a week or more. Now that's consistent with the 2014 DoD-VA guideline for obesity, which recommends, at least for overweight patients, that they get 150 minutes per week of moderate intensity physical activity to help with weight loss. There are 2 recommendations under mind-body therapies, and the first deals with some choices for patients that are interested in complementary and alternative medicine. The research on these isn't nearly as strong as it is for most of the other research that was evaluated, so the strength of the recommendation is a weak 4 for these items. However, the committee did see that there was a moderate body of evidence that Tai Chi does not lower blood pressure, so there's a strong against about recommending Tai Chi solely as a way to lower blood pressure. The DASH diet has great literature showing how it can lower blood pressure, so it gets a strong 4 recommendation. However, it's important to note that they specifically recommend a dietitian-led DASH diet and not simply giving the patient a handout on it. Of course, this depends on your local resources being available and able to support these kind of referrals. We do have a link to more information about the DASH diet if you don't have the ability to easily refer your patients to a dietitian. Now, if your patient has other cardiovascular risk factors, such as dyslipidemia, it might be a Mediterranean diet would be more appropriate for them. There is a weak 4 for that particular recommendation. The last 2 lifestyle recommendations deal with sodium and alcohol reduction. There are strong recommendations for both of these. The first is to lower sodium intake to less than 2,300 milligrams a day. As far as alcohol consumption, our hypertensive patients should limit their alcohol intake to less than 2 drinks a day in men and 1 drink a day in women. The blood pressure reduction for both of these interventions is kind of small, but it is statistically significant. Now during this training, you've seen how the details from the CPG are available to review right on the Metabolic CPG AIM form while you're at the point of care. I'll finish up by highlighting a few other features of this particular AIM form so you can see how it might help you when you're seeing these patients. First off, hypertension is just one of the 4 clinical practice guidelines that are covered on the Metabolic AIM form. Many patients with hypertension also have other diseases, which is why we've placed the clinical practice guidelines for hypertension, diabetes, dyslipidemia, and obesity all together. And just like how the hypertension guidelines have been updated recently, so have the DOD-VA clinical practice guidelines for dyslipidemia and obesity. The diabetes guideline will be updated in 2015. We'll always update the same form with the latest version of these 4 guidelines, so by using it, you can be aware of the updated recommendations. Second, there are some additions to the Physical Exam and Review of Systems tabs to make it easier to document specific history and exam elements that are called out in each of the guidelines. We've color-coded any element that is mentioned specifically in a particular CPG. Now we aren't saying that that's a complete exam for the condition, but they are mentioned explicitly in the clinical practice guideline. And some of these specific elements aren't found on the basic exam or ROS on the core AIM form. Finally, there are a pair of chronic care plan or CCP copy forward boxes that have been placed on the front tab of the Metabolic AIM form. One is for obesity, which we'll cover in a separate training. The other covers hypertension, dyslipidemia, and diabetes. In the paper record, we used to frequently have a cover sheet that summarized the most important details about a patient's diagnosis. The CCP is as close as we can get to that within Alta. So how does it work? Well, looking at the guideline, one of the steps is to determine a blood pressure goal. Where would you place that goal in the chart so that the next provider of care knew what it was? This CCP gives us a section to summarize details like that. If a patient only has hypertension and not the other disorders that are covered, you can simply erase whatever doesn't apply to the patient. And it doesn't have to be completed all in the first visit. It can be filled in more over time. We also give you links to resources like to the CPGs themselves, along with links to other tools such as the 10-year cardiovascular risk calculators, which are a big part of the dyslipidemia guidelines. And as an added bonus, completing this section will help you to meet one of the NCQA standards for patient-centered medical home recognition. Well, that finishes up our quick review of the updated hypertension clinical practice guideline for the Department of Defense and Veterans Affairs. Check the resources link at the top of the page to get a link to the entire guideline. Thank you for listening and have a great day.